Hello and welcome. I'm Rebecca Ganetzky, and I am an attending physician at the Children's Hospital of Philadelphia, and I'm a biochemical geneticist.
Hi, everyone. I'm Amy Goldstein, and I am a child neurologist and also in the mitochondrial medicine program at the Children's Hospital of Philadelphia. Part of this talk was also worked on by our previous nurse practitioner, Beth Heyer, and our previous Mito fellow, Ed Shadiak.
Hello, everyone. I'm Divakar Mithal. I'm an attending physician at Ann and Robert H. Lurie Children's Hospital of Chicago and in the Department of Pediatrics at Northwestern University. I'm also a child neurologist and I have an interest in mitochondrial disease, neurogenetics, as well as neurocritical care.
So the three of us are going to present a session called ICU Critical Care. And we all manage sick patients in the ICU. Rebecca and I more as consultants, and Dr. Mithal more as the neurocritical care doctor, really hands-on involved in care. But what we're bringing to you is our experience of managing children and adults with mitochondrial disease who end up needing intensive care due to multiple medical issues. So we're going to present several cases for you so that we can talk about some of these critical issues. Case one is a patient with a mitochondrial disorder where they presented with stroke-like symptoms, and a brain MRI was obtained that shows a new stroke in the brainstem. And so the question is, how would we manage that? And as you can see here, at age 2, our patient had just a few small lesions in the basal ganglia that contributed to getting the genetic testing and verifying that she in fact has a mitochondrial disease. And here by age 15, we can see what we consider the natural progression of Lee syndrome. This is a patient who has an ATP6 mitochondrial DNA point mutation. And so we can see again, just some faint lesions here at age 2 turned into bigger lesions with more necrosis and higher signal intensity in the basal ganglia, the caudate nuclei, which are now much smaller, and also the putamen, bilateral and pretty symmetric. So again, very typical of Lee syndrome. And what happened was she was sick for a few months, a few winters ago. And when she came in to our emergency room, she had presented with some eye movement abnormalities and some increased drooling. And so when she first came into the emergency room, she had an MRI that showed some intensified lesions in her brainstem area and in her lower brainstem, and as well as the cerebellum. And hopefully you can see my mouse, I'm pointing over some whiter, high intensity areas in her cerebellum. We stabilized her and she was very stable at that time and had some, a little bit of a fever management issue and got some fluids. But 3 weeks later, she came back with now difficulty swallowing, difficulty speaking, and many more what we would call bulbar symptoms. And so as you might be able to appreciate the change in this MRI, if we look at the brainstem here, where these two darker circles are the red nuclei, now we see a lot more white, higher signal behind that, extending up into her optic tracts. We see more cerebellar lesion in the center. We see some more lower brainstem lesion, and we see where there was just some faint white on this one side. Now we can see the cerebellum really has a lot more involvement. And again, this is pretty common for our patients with Lee syndrome who experience an acute decompensation from something like a viral illness. This can become a neurologic emergency. So what we told our emergency room is she now has new brainstem lesions. She's already sitting there having more drooling, trouble swallowing. This can progress to acute respiratory failure very quickly. Why? Because in our lower brainstem is our respiratory center. And when you have Lee syndrome, it can be a very unfortunate place for a new lesion to show up and shut down the breathing mechanisms. So we start thinking about what can we do to treat? How can we help stabilize this patient? So we're going to go into some general ICU management considerations for mitochondrial disease. And rather than focus on neurologic considerations for the time being, I'm going to turn this over to Dr. Ganetzky, who will fill us in on some of the metabolic issues and general medical issues to focus on.
So I think when I think about what I want all of my families to know about what to expect when their child is in, or their family member with mitochondrial disease is in the intensive care unit, the first thing that I need you to hear is that there's no correct treatment for mitochondrial disease in general. And so each time that someone in your family is in the ICU, different things may happen. And if you call your friend and ask them how their ICU stay was, you may hear a different type of ICU stay or story. But overall, our goals of taking care of the critically ill patient with mitochondrial disease is to reduce the metabolic stress, which means how much energy they need to make for themselves versus how much energy they're getting in, to treat infection, which we know is a source of stress because the body needs a lot of energy to mount a response against infection. And then to think about the person with mitochondrial disease and what organ systems are involved in mitochondrial disease, what could be going on that could be making that person sick, and how we could fix or manage that organ. So when I first get the call that one of my patients is in the ICU, these are the things that I do first. I say, where are they spending energy that they don't need to be spending energy? The easiest way to stop our body from spending energy is to keep our body at a normal temperature, because it takes a lot of energy to make that body hot, and then it stresses out a lot of symptoms. So if there are fevers, I treat them, and I treat them with acetaminophen and ibuprofen. And then if I need to, I treat them with mechanical cooling. We look for a source of infection, and if there's an infection, we treat it. And if there's not an infection, many people with mitochondrial disease have dysautonomia, which means that their sympathetic nervous system is not typical, and they can have a high temperature just because their body has decided to have a high temperature, and there's treatments for that too, which Dr. Mithal will tell you more about. And then, is there any reason why this person has gotten acutely sick? If they have an infection, we treat it. If it's flu, we treat it with Tamiflu. There are other preventative measures, such as whether they're dehydrated or haven't been eating well, or some of my patients even can decompensate from emotional stress, and then working on emotional triggers is important as well. That's all taking down the amount of energy people are spending. The other way that we can reduce metabolic stress is increase the amount of energy we're giving people. And so I think about, how am I feeding this person? Am I giving them feeds? Am I giving them IV nutrition? And then I think about, we have 3 types of nutrition we get. We get carbohydrates, we get protein, and fat. And people with mitochondrial disease don't use any of those things perfectly, but they can use each of those things. And so I try to balance carbohydrates and protein and fat so that the patients are getting all 3 as early as possible to prevent catabolism. In general, human beings use our guts to eat. That's how our bodies were designed to work. And our bodies work the best that they can using food that goes into the gut. You get the most balance of nutrients, of antioxidants, of vitamins in gut feeding. And so if I can use the gut to feed a patient, I do use the gut to feed a patient. And then I think about the organs. So I think about, is the autonomic nervous system working? And I test for that. I think about, our hormones working, especially the stress hormones that help our bodies respond to stress. Is that happening appropriately? And I test for that. And then I check the big solid organs, liver, kidney, heart. Are they working? And can I support them working better? And then I call Dr. Goldstein and I make her check for specific neurologic problems like seizures and stroke, and think about how to manage that. I'm going to hand this over for a second to Dr. Goldstein to go back to case 1 and talk about, what do we do for acute lesions and Lee syndrome?
Great, thank you. So getting back to our patient, who we're now very concerned about with the new brainstem lesion causing potential impending respiratory failure, meaning intubation, being on a ventilator. What can we do to help rescue the situation? So one of the treatments that we commonly use here in the United States is IV arginine for acute metabolic stroke. This was developed for MELAS, which is more of a cortical, or the brain tissue, the gray matter tissue lesions, and it can work very well for MELAS-related strokes. Well, what about for Lee syndrome? We think that the potential benefits outweigh any risks for giving IV arginine. And so we use the same protocol, which is 0.5 grams per kilogram of body weight per day up till 5 days. There are times where only a few days, 2-3 days, might help resolve some of the symptoms. So it doesn't have to be for a total of 5 days, but it can be up until 5 days. Some of the questions that come up is, what about prolonged therapy? Or what about repeating the therapy if new lesions show up the following week? And we have not seen a problem in doing so. And in fact, I have a patient in the hospital right now that I share with Dr. Ganetzky who has new lesions that showed up on an MRI. And we're continuing the arginine even though he's been on it already for a couple of days. And is there any evidence it's effective in non-MELAS related metabolic stroke? And there will be more to say about this on the next slide. The next medicine that we consider giving at CHOP, and again, this is not universal at this point, is to consider giving high dose steroids. And when I say high dose, these are super high doses. This is the dose that's used in multiple sclerosis exacerbation and in something called ADEM. ADEM stands for acute disseminated encephalomyelitis. So children without mitochondrial disease can get a post-viral syndrome where they have a lesion on the brain causing seizures or altered mental status, and that's very treatable with high-dose steroids. So when we first get the MRI of our patient with mitochondrial disease, my number one question for my neuroradiologist is there edema, and what kind of edema is there? Is it vasogenic edema, which means it's reversible and maybe amenable to steroid treatment, versus cytotoxic edema, meaning that there has already been some cell death and the swelling that's there is not amenable to steroid treatment. And the good news is usually in metabolic stroke, whether we're talking about MELAS or Lee, it's usually a mixture. It's a mixture of vasogenic and cytotoxic, meaning that some of the swelling on the brain is potentially treatable with high-dose steroids. And sometimes there's also some swelling of the myelin, the white matter. Again, using models like multiple sclerosis as our lead, can we use immune therapy to help reduce the size and impact of this lesion? Steroids have consequences, and this is why it is not a universal consideration. And Dr. Ganetzky and I spend many hours on the phone together discussing what's the risk versus benefit for this particular patient at this time. Are we going to cause more problems with steroids or more benefit with steroids? And if we cause more problem, even in the setting of giving steroids, can she help that patient, whether they develop high blood sugar, increased lactic acidosis, etc. So Solu-Medrol is something that we absolutely consider when we have a big lesion causing problems in the brain, especially ongoing seizures or an impending respiratory event. The next medicine that we continue to work out here at CHOP with our pharmacy is something called N-acetylcysteine. N-acetylcysteine, or NAC, replenishes the body's #1 antioxidant, which is called glutathione. And this is a very common therapy used when somebody has a Tylenol overdose to help rescue the liver failure. We think that N-acetylcysteine can be helpful in our patients with mitochondrial disease that are in an acute crisis because we're assuming that their glutathione supply just gets depleted. They're fighting lots of oxidative stress. One limitation of this, however, is that N-acetylcysteine, it actually gets into the brain quite well. It crosses the blood-brain barrier, but it exits almost immediately. And so the question is it going to be helpful rescue at all for our patients with new brain lesions? Can we ask ICUs and hospitals to follow their typical Tylenol overdose protocol? And what about the inhaled or enteral form using the gut versus an IV form? Because if a patient is awake and taking oral NAC, it's actually pretty nauseating and people could vomit. And so in that case, if it's too dangerous to give that way, then the IV form is preferred. Again, this is not universal treatment. These are the things that we consider every time a mitochondrial patient is in our ICU here at CHOP. And we wanted other people to know that we're using this particular set of therapies. Why look at this for non-MELAS patients? Well, Dr. Ganetzky and Dr. Falk at CHOP looked into this a few years ago, and they did an 8-year retrospective analysis looking at using IV arginine therapy for acute metabolic strokes and pediatric mitochondrial disease. And they found 9 pediatric patients who had had a total of 17 stroke-like episodes. Their age range was anywhere from 1 to 23. You can see that they had different genetic causes for their mitochondrial disease, some nuclear genes, some mitochondrial DNA related genes, some were Kern-Serre syndrome, some were Lee syndrome, and some were more Milos-like. And what they found is that the clinical response was more favorable if the IV arginine was given immediately as soon as that patient presented, if the symptoms were more unilateral, meaning one arm or leg was weaker or having seizures on that side. They found more benefit for the patients that had a mitochondrial DNA mutation versus somebody with a nuclear gene mutation. And granted, this is only 9 patients, so we want to do more study in this area. And then the patients that were older at the time of presentation seemed to benefit more. So in other words, if there's a child who's very young, who has central lesions in the brain that don't have a lateralizing feature, meaning it wasn't unilateral, it was more of a respiratory issue, they did not necessarily benefit compared to the other patients. However, we have continued to give arginine to our patients with acute metabolic stroke here at CHOP. So we're going to review very quickly what is mitochondrial disease, what are the other organs, and this is again really focusing on ICU management, because what we've learned is that if somebody's in with a stroke, new stroke and seizure, they could then all of a sudden develop another organ becoming involved. So we've already gone over brain symptoms for presentation. Some of our patients, especially if the stroke is in the back of the brain, they could have cortical vision loss, or they could develop some acute vision problem. But sometimes our patients have ongoing ptosis and ophthalmoplegia, so the lower eyelids and the eyes that don't necessarily follow. Our ICU needs to know that, so they're not looking for the quote unquote normal eye response or normal eye exam. And optic neuropathy, a sudden change in the optic nerve, can happen suddenly during a crisis. We worry a lot about the heart. And in fact, we had a child in with Milos, and she started having trouble breathing after we got her strokes and seizures under control. And we said, please get an echo. And in fact, she was in new left ventricular heart failure. So it's very important for us to make sure the ICU is looking at the heart, either with an echo to look for cardiomyopathy or any signs of heart failure, or a new arrhythmia, heart block, or Wolff-Parkinson-White, or any other type of cardiac arrhythmia. These are treatable and preventable, and so it's very important for us to make sure they're looking at the heart. The liver can get involved quite suddenly anytime somebody's in, again, with one problem. The liver can flare up, especially if somebody's having seizures or gets exposed to Depakote and they have a contraindication to Depakote use, like Pol-G, for example. The gut, especially when our patients are in the ICU, and if they've had a procedure and are getting narcotics post-operatively, or if they've needed anesthesia or sedation, that can cause what we call an ileus. The gut can shut down. And we see this in our mito patients all the time. What does this mean? This means that our patients might not be able to tolerate their usual feeds, even if they're on tube feedings. So we tell the ICU, we need bowel rest. Make sure you start TPN early, not days and days of IV fluids only, but make sure we're getting protein in. And then when we restart the feedings, not assume that that patient's going to be able to tolerate the full rate. They may need to be gently back on feeds and more slowly, watching for things like pseudoobstruction and making sure that we're supporting any dysmotility. Finally, our patients, as we know, can suffer from exercise intolerance, fatigue, hypotonia, and rarely they can have rhabdomyolysis, which means muscle breakdown. So that's when the CK levels go very high and you need a lot of extra fluids to help protect the kidney. Okay, I'm going to turn it back over to Dr. Ganetzky for the next few cases.
So one of the first questions and concerns that comes up in the ICU, sometimes even before the neurologic calls come, is calls about liver function, lactic acid, and fluids. So I learn so much from cases. So this is why this is a case-based study. So we'll tell you as we go about choices that we made for real life patients. So I got called that I had a 3-month-old baby girl who was in the ICU with acute liver failure and lactic acidosis. The ICU was very concerned because they told me that she was very acidotic, And there's a couple of different ways that the ICU can decide that someone's acidotic. One is to look at a blood gas, which is what I'm showing you here with the pH and the CO2 and the bicarb. That's the best way to tell whether this is a metabolic acidosis or a respiratory acidosis. The other way is to look at something called the CMP or a BMP, which can tell you what the anion gap is. And they did that and they found that she had a very high anion gap. And also they checked her lactate and her lactate was high. I'm not showing you units here. I always talk about and think about lactate in milliequivalents per liter. Some of you think about lactate in milligrams per deciliter, at which point 18 is a totally normal lactate. So if you have a lactate that is 18 milligrams per deciliter, please do not panic. You do not need ICU care. I should be a better doctor who uses units more consistently. I'm sorry about that. So they called and they said, this is a very severe acidosis, and I think it's a lactic acidosis. So how do you know that someone has acidosis? And then the next question that always happens is I get called by ICU doctors and they say, I think the lactate is going to cause a stroke, or I think the lactate is going to cause neurologic damage. And so the question is, when is lactate bad and what do you need to do about it? So we've talked about how do you know when there's acidosis? You know there's acidosis because the pH is less than, depending on your lab, somewhere around 7.35. The bicarb is low, and a normal bicarb is, again, depends on the lab, but I like to use 20 as my cutoff for normal bicarb, or the base excess is negative. And again, it's really important to tell whether someone has respiratory acidosis, which can happen when someone's not breathing enough or breathing effectively, versus a metabolic acidosis, which can happen in mitochondrial disease for a number of reasons, because those things are treated differently. Lactate, if I teach you anything, if you remember anything I say, what I want you to know is lactate is not bad. Lactate is good. We all make lactate. And it's not unusual that some of us will have high lactate as we go about our day. If you just ate a big bowl of like pixie sticks, you just had a lot of carbohydrates, your lactate will be abnormally high. If everyone gets up and runs on your treadmill while you're listening to me talk, your lactate will be high. Lactate is a way for our bodies to make energy quickly without using the mitochondria. Lactate is never toxic, but lactate is an acid and it causes acidosis, and that acidosis has to be managed. But once the acidosis is managed, lactate does not cause strokes. It does not cause seizures. It does not cause neurologic damage. All of those things can happen in mitochondrial disease, but they don't happen because of the lactate. There are lots of other causes for people with mitochondrial disease to have metabolic acidosis. People with mitochondrial disease may have ketoacidosis because they can't oxidize ketones, which is what we use when we don't use sugar for energy. And sometimes doctors will say, oh, your child doesn't have ketones because I checked their urine for ketones. But the urine that we dip for ketones isn't very sensitive in mitochondrial disease. And so they should check for a type of ketone called beta-hydroxybutyrate, which is in blood. You can have lactic acidosis, and people get really, really, really scared of lactate. But actually, most people with mitochondrial disease do not have significant lactic acidosis. They have high lactic acid levels, but that doesn't necessarily need to be treated in any way because lactate is a very weak acid. So you don't usually start seeing lactic acidosis that needs to be managed until the lactate is about 5 or higher. Many people with mitochondrial disease do have acidosis from renal tubular acidosis. They may not even know that they have renal tubular acidosis. Renal tubular acidosis is when your kidneys don't have the energy that they need to reclaim nutrients out of your pee. And then they pee out bicarbonate, which is the body's main base. And you can have primary renal tubular acidosis, where that's the cause of your acidosis. But also mitochondrial kids who have acidosis for other reasons and are getting treated with sodium bicarbonate to try to buffer their acidosis may need more bicarbonate than other children with the same degree of lactate or ketones because they're peeing out their bicarb and they may need more. Lots and lots of things that can happen to you or your child in the ICU will make your lactate go up higher. And the number of families who call me all the time and they say, Dr. Ganetzky, you have to get me out of this ICU. They don't know what they're doing. My child's lactate was 3 and now it's 5 and they're not doing a good job. And I say, let's take a calm breath together. Lots of things that are the right thing to do can make the lactate go up. It does not mean that you or your child are getting sicker. It just means that the lactate is going up. Things that can happen that are good for your kid that will make the lactate go up include vasopressors. Anything that makes your blood pressure go back towards normal does it by making there be less blood circulating in your hands and feet. Your hands and feet aren't super happy with that, and they will make lactate go up as a result, and that's okay. And sometimes people will say, well, which blood pressure medicine should I use? Should I use epinephrine? Should I use norepinephrine? Should I use vasopressin? They all will do this. Lactated ringers or any dialysis fluid that has lactate come buffered. So they won't cause acidosis, but they will cause the lactate to go up. And then sugar. We'll talk about sugar in a second. Mitochondrial patients need sugar to make energy. They need some form of carbohydrate. And if they are only getting IV, the only IV carbohydrate we can give them is straight sugar. That is good. They need energy. And as we do that, lactate will go up. And the more sugar you give them, the more lactate they will have. That's okay if that's what needs to happen next. How do we treat mitochondrial acidosis? Most patients with mitochondrial disease need direct base, which is bicarbonate. There are other buffers that we use, which I've shown here in green, called acetate and citrate and even lactate itself. And each of those work by your body taking those in and generating bicarbonate as part of your TCA cycle. The TCA cycle is part of how our mitochondria make energy, and people with mitochondrial disease don't do that totally normally. So giving people with mitochondrial disease these other buffers like acetate and citrate may not result in them generating bicarbonate and may not work. The right amount of bicarbonate to use to treat acidosis is patient specific, it's weight specific, and it may change over time. It's given based on the observed acid-base status, so it can be very, very different from patient to patient. And they may need more bicarbonate than you think that they will because they'll urinate out the bicarbonate very easily. Sometimes patients, again, call me really upset and say, Dr. Ganetzky, you've got to get me out of here. They keep giving bicarb and they've given it like 7 times and the bicarb still isn't normal. And I say, it's okay. I would rather them guess and check and keep guessing and checking and end up at the right number eventually than overshoot with the bicarb, because too much bicarb can make you breathe very fast and that can be very dangerous. And also, I usually like to give half the bicarb in the first 1 to 3 hours and the next half that someone needs over the next 24 hours so that we don't overshoot. So it's normal that it'll be lots of different batches. Okay. So this is a 3-month-old infant who came in with failure to thrive and hypoglycemia. So the first lactate is 4.8. That's not very bad, right? Doesn't cause severe acidosis. So they give sugar, right? She's sick, she needs IV fluid, she needs nutrients. That's what I just told you. And so they give her lots of sugar. And now her lactate is 10. So they give more sugar and the lactate goes to 14. So dextrose increases lactate, especially in babies with mitochondrial disease. And that's okay. And 14 is very high as a lactate. So you have to know that that's going to be what's going to happen next. You have to have a plan for how to buffer that acid. So one of the biggest concerns people always ask me for is an emergency plan for what fluid they're going to get when they have mitochondrial disease. I think about their lactate. Is this someone who's prone to lactic acidosis and I need to watch their sugar? Lactate isn't toxic, and so it might be okay for it to be increased, but I have to think about the risks and benefits. So I think about the more sugar I give will increase lactate, but the benefits of sugar are preventing low blood sugar. Not all mitochondrial disease patients have low blood sugar, but some do. And limiting catabolism, which means breaking down your own body for energy, but sugar is not a great energy source. And so when I'm giving it just for that reason, I try to give other nutrients as well. Another fluid that sometimes people use is lactated ringers. And lactate is, again, it's a buffer. It generates bicarb from the TCA cycle, but in severe mitochondrial disease, it will not buffer them and it will make the lactate worse instead of the acidosis better. So you need to anticipate that. So sometimes you'll be told that's fine. LR doesn't increase lactate. And it's true, it doesn't in typical kids, but it does in kids with mitochondrial disease. So the last case I'll tell you about is a 5-year-old boy with Lee syndrome who presents with a rapid flu positive test. So this is case 4. So he's an ambulatory verbal child with hypotonia and ataxia. But now he's not talking or not eating and not following commands. So something has gone really wrong. He's responding only to pain, but fixing to faces, meaning he looks at you. And he has a temperature of 101 at home. And he has very severe acidosis. And he has normal blood sugar at 76, which is just at the lower end of normal. And the lactate is normal, and there's not an anion gap. So this is not lactic acidosis. So what's causing this acidosis? So it's not lactic acidosis. Ketoacidosis should also have an anion gap, so it's not ketoacidosis. So what's going on? So he has likely severe dehydration from renal tubular acidosis. Mitochondrial patients, the same way that they can't reclaim bicarb in their kidneys, can't reclaim fluid and other electrolytes from their kidneys. They are more sensitive to dehydration. The stress from infection also puts them at risk of decompensation. And using sugar for energy is not efficient. So the metabolic stresses of having low blood sugar may start early, even when blood sugar is at the lower end of normal, like 76. The concern here is that he's losing important electrolytes from his renal disease, which may not have even been identified as renal disease before this happened. And we talk about catabolism, which is breaking down your body for energy, which increases the risk of a neurologic event. And also this could be associated with having high ketones because of poor ketone utilization. So now I'm going to turn it over to Dr. Goldstein, who will talk about what happens if you have one of those neurologic events because of dehydration.
Okay, thank you so much, Dr. Ganetzky. And I just want to, if it's not already apparent to all of you, it's amazing to have a partnership between a biochemical geneticist who can help manage the lactate, the acidosis, and the fluids, and a neurologist who can help manage the brain issues, a neurocritical care doctor who can really manage any acute neurological problems, and then, of course, the rest of the ICU team and any other needed specialists. Such as the cardiologist, the pulmonologist, ENT. Again, this becomes a very multi-systemic collaborative effort, and it's really great to have all of the team members present and working with the Mito team to help understand what's happening and what's the underlying disease and what other problems might come up. So as Dr. Ganetzky said, we're going to move on to case 5. This is a 14-year-old who has complex partial seizures. And this is a patient who had longstanding seizures and was already on some anti-epileptics without good control. Previous medications included trileptal, or the generic is oxcarbazepine, and phenobarbital. The past medical history is also notable for a peripheral neuropathy. So we have central nervous system involvement from seizures and peripheral nervous system involvement with the neuropathy. Depakote, or valproic acid, was added for seizure control. And 30 days later, he presented with jaundice and severe abdominal pain. The AST and ALT, which are liver function tests, LFTs as we call them, were markedly elevated. The normal should not be above 40. And here, this is 2,000 and 1,800. The INR was slightly elevated at 1.3. This is a clotting factor. And the total bilirubin was slightly high at 7.1. And the amylase and lipase, which are pancreatic markers, are highly elevated. And I should mention, this is a case that was adapted from Rustinato and published in Seizure Journal in 2011. And also Dr. Stewart in a hepatology journal in 2013. And I should also point out that there was no genetic testing done prior to giving this child Depakote. And I will also add, as a child neurologist, many child neurologists use Depakote, especially as add-on therapy when other medications are not working, but we're going to talk about some of the caveats to that, especially with the help of Dr. Sinedo and Dr. Cohen and the Mitochondrial Medicine Society helping to publish standards of care for mitochondrial disease. So the question here is, what happened? Well, this is a classic case of mitochondrial toxicity. This patient had polymerase gamma mutations, or POLG, and the outcome when you give somebody with POLG Depakote or valproic acid is that they can go into fulminant hepatotoxicity, fulminant liver failure due to this drug. I want to backtrack though and tell you, I know Dr. Ganetzky just presented about lactated ringers and the rationale for not using it when the lactate can't buffer somebody with mitochondrial disease properly, and then it only helps contribute to increasing the lactic acid. But there are less and less contraindications to mitochondrial therapies at this point in time. So, years ago, if we went online and even some of our patient support groups like the UMDF, there would be a long list of medications not to use in case of mitochondrial toxicity. Lots of drugs are called mitotoxins, but most have their place, meaning their use, the benefit outweighs any potential risk. If we added any of these medicines to a dish filled with mitochondria, there could be some toxicity, but in the human body in vivo, that there's some additional safety mechanisms, and the toxicity is more theoretical than it is actual. So again, in most patients, what do we contraindicate? Again, valproic acid, especially if somebody has POLG, but I will mention that valproic acid has been used safely in other mitochondrial disorders, such as MELAS and MRF. Another organic acid that can be tricky to use is salicylates. Use with caution is the next list, and this includes the volatile anesthetic, so anesthesia that's given by gas that can be very harmful, especially to patients that have complex 1 deficiency. Propofol, same thing. Some of our patients with MELAS or complex 1 disorders will have what's called propofol infusion syndrome after surgery, where they have very high lactic acid, and they may even go into rhabdomyolysis, and it can be very dangerous. Propofol can be used safely, and we do recommend that it's only used on induction of anesthesia, meaning less than an hour's worth of use. So a very short case or at induction of more general anesthesia, but certainly not for a prolonged period of time for mitochondrial disease. The other medicine is an antibiotic called gentamicin, which is in this category of aminoglycosides. And there is an increased risk of gentamicin-related hearing loss, especially for a single mitochondrial point mutation at 1555. However, if somebody needed another antibiotic that's in the aminoglycoside category, it is not worth the risk of dying from an infection with a potential risk of an antibiotic. And again, if we remember that mitochondria were likely bacteria that, again, kind of melded with our primordial human cells, antibiotics are going to potentially be mitochondrial toxic if the role of the antibiotic is to kill a bacteria, but that does not mean to avoid antibiotics. And I've personally seen parents that were very worried about their child receiving antibiotics, and that child was then in the ICU with horrible pneumonia for months. So again, we have to weigh the risk versus the benefit of all potential medicines that you might be worried about. Typically, the benefits outweigh the risks with ibuprofen unless there's severe renal disease, acetaminophen unless there's severe liver disease, and of course, the other specialists we rely on to ask either GI or renal, is it okay for this patient to receive ibuprofen, or our liver specialist in the case of acetaminophen. Again, fever is a very potential threat for causing more catabolic stress, so we don't want somebody to have fever and nothing to use. So again, we have to have these discussions. Again, most antibiotics, the benefit is going to outweigh the risk. And again, I've already summarized this case. This is a teenager who had complex partial seizures that was not responding to other meds. Depakote was added. The other clue here was that there was also some pre-existing neuropathy, and this patient may have deserved a genetic workup prior to getting Depakote. So we avoid true mitochondrial toxins is critical, because this then caused a fatal fulminant hepatic failure for this patient in particular. And I mentioned that there's a lot of work that's been done. I'm going to forget all the authors, but I know Restinito was on this article, Mary Kay Koenig was on this article, and there's a big push to check for Pulgi before adding Depakote. As a child neurologist, we all learned that Depakote is not safe before age 2, but afterwards it should be okay, and we know that's not the case. Pulgi can present at any age, so there's nothing magical about a certain age number when it comes to adding that as a drug. And again, almost all medicines have mitochondrial toxicity in vitro in the dish, but it's typically tolerated well in humans. Next case 6, is a 2-year-old boy undergoing evaluation for regression. And I believe we're going to switch over to Dr. Mithal for case 6 and 7.
For case 6, we will be discussing a 2-year-old boy who's undergoing evaluation for developmental regression. This is a 6-year-old boy who had typical development until 14 months of age, when a global developmental neurologic delay was noticed. He is now 2 years old, recently had a fever. He stopped walking and stopped eating by mouth. As part of his evaluation, he was given general anesthesia for a muscle biopsy and a brain MRI. The MRI showed bilateral T2 hyperintensity in the putamen. Post-anesthesia, extubation was difficult. He is no longer initiating independent respiration, and he required re-intubation. As part of his evaluation, he had an echocardiogram that showed new left ventricular hypertrophy. The question is, what happened to this child who, until a few days ago, was sick with a fever and had some developmental regression, but now has new heart disease? Acute cardiac complications are a feature of some mitochondrial diseases. In this case, a 6-year-old who presented with Lee syndrome developed acute left ventricular hypertrophy in the setting of anesthesia. Sometimes this is transient and can resolve over a few months. However, monitoring in the acute period is critical such that further complications do not arise. People with mitochondrial disease with a previously normal heart function can still have decompensation. The risk is specific to the type of disease, but it may develop suddenly. And the onset is usually associated with a stressor, such as drugs or an infection. In this case, it was anesthesia. Acute dysfunction can be related to the heart pump, such as a cardiomyopathy, where the heart muscles that pump blood throughout your body are not functioning properly, or they can be related to the rhythm of the heart, or an arrhythmia. In both cases, a cardiologist should be involved. The take-home message here is that acute heart disease is a serious complication. Whether it's dilated cardiomyopathy, which is the most common form, or hypertrophic cardiomyopathy, or one of the arrhythmias, a cardiologist should be involved. And acute management is critical. For the acute management of cardiac complications, a few basic principles apply. All physicians should be seeking mitotoxic medications to remove them, such that the patient's injuries do not worsen. In addition, they should be looking for metabolic support in the form of arginine and coenzyme Q10, which the patient may be on if they carry a prior diagnosis of mitochondrial disease, and if not, add them to the mix. There should be aggressive correction of the bicarbonate for pH balance, and we should be normalizing the carnitine if the serum level is low. Antiarrhythmic medications should be added in consultation with a cardiologist, and repeated echocardiograms and electrocardiograms throughout the metabolic crisis to ensure no worsening of the disease are critical as well. In summary, the primary goals of acute cardiac complications due to mitochondrial disease are to 1. Remove toxins or stressors, 2. Provide metabolic support, and 3. Have close cardiac monitoring, all with the support of a cardiologist. For case 7, we will be discussing a 6-year-old with Lee syndrome that acutely worsens for unclear reasons. This is a 6-year-old with Lee syndrome who develops rigid muscles, is sweating profusely, and has an elevated heart rate. The child is admitted for management. The labs are fine. Vital signs are essentially normal with the exception of the heart rate, and there are no missed medications as far as anyone can tell. He is found to have a new sacral ulcer on his lower back that has a wound that is open. What has happened in this case? Children with mitochondrial disease may develop autonomic storming, or another term is paroxysmal sympathetic hyperarousal due to this painful injury. These are essentially forms of autonomic dysfunction. They may occur in many mitochondrial patients, particularly in Leigh syndrome. However, some other forms of mitochondrial disease may have other manifestations, including gastrointestinal signs like dysmotility. These events are usually triggered by a stress or injury. They can be confused for seizures or a toxic ingestion, and the management is different, but does have two parts, which we will review briefly. The management of sympathetic hyperactivity in the acute setting has some very basic principles. Firstly, we would break the storming cycle. As children's sympathetic nervous system becomes more active, it is hard for it to stop. In order to slow the severity of symptoms, using an analgesic or a sedative can be helpful. In addition, we seek to reduce metabolic demand, and of course, we would like to remove any triggers that might be making the sympathetic hyperarousal worse. During the crisis, in particular, starting a dexmedetomidine drip can be very helpful to break the cycle. An alternative is to use individual doses of morphine. Both of these methods are quite effective. We do recommend caution in using benzodiazepines, as that may induce respiratory suppression in an otherwise critically ill child. However, if benzodiazepines are used regularly in the patient, these may also be an option. If the sympathetic hyperactivity is due to a fever or some kind of infection, trying to reduce metabolic demand using Tylenol or ibuprofen may be helpful. And then a head-to-toe nursing assessment is critical to identify any physical triggers like bruises, rashes, or, as in our current patient, a wound that is new. The management of sympathetic hyperactivity after the cycle has been broken initially is more of a subacute transition from hospital management to home management. The goal is to transition from drips or narcotics that are being given in the hospital to a maintenance regimen that can be done at home. These are medications that may be on for a long term, and we would like to consider the side effect profile in doing so. Also, if there are specific autonomic symptoms that are present for a patient, we would target those as well. The first line of transition medication is usually gabapentin, as that covers a wide range of autonomic dysfunction and helps patients transition away from medications like dexmedetomidine. Other medications for specific symptoms include propranolol for an elevated heart rate, clonidine for elevated blood pressures and heart rates, baclofen or Valium for spasticity, Sinemet or dantrolene for dystonia, other medications for pain management, and even other medications still for gastrointestinal dysmotility and other symptoms that may arise. Each of these symptoms should be discussed more carefully prior to starting a maintenance medication, but may be needed in order to reduce a cycle of autonomic instability in the future. In addition, once a patient has demonstrated a propensity for having autonomic storming or a cycle of sympathetic hyperactivity, it is good to have a rescue plan for home, whether that's a single dose of morphine for the patient, or if it's been tolerated previously, a single dose of a benzodiazepine to break the cycle of storming at home, which, if it fails, would prompt evaluation by medical professionals. In addition, parents and family and caregivers should try to reduce metabolic demand during episodes of sympathetic hyperactivity.
Okay, thank you very much, Dr. Mithal. Back to me. I'm going to talk about case 8, a 9-year-old boy with a history of Kearns-Sayre syndrome. He presented with hypocalcemia, so low calcium. So what we know is that primary hypoparathyroidism occurs in some mitochondrial diseases, and especially Kearns-Sayre. There are other causes of hypocalcemia, such as renal wasting, secondary hypoparathyroidism in renal disease, but we can also anticipate a patient having stress hypocalcemia with procedures. In fact, a few weeks ago, one of my patients with Kernsair syndrome came in to have cochlear implant inserted, and we had a whole plan with endocrine to watch him for stress hypocalcemia. He already has known hypoparathyroidism, is already on calcium supplementation, but we were worried that the surgery would put him over the edge. So we check ionized calcium and we check phosphorus. And for our patients with especially Kernsair, we consider supplemental calcium use. Some of our patients with Kernsair will present acutely with low calcium. They can come in tetany, where they have tetanic posturing of the hands. They can also present with seizures if the calcium gets low enough. I've even had one patient with Kernsair syndrome develop rickets and need to be hospitalized. And I'm sorry, there was a little reversal here. So this is a patient that came in for an elective G-tube placement due to poor weight gain, as is common in Kernsair. His routine post-operative blood gas showed an ionized calcium of 0.99, so a little on the low side, but his total calcium is very low, 5.6. So again, what happened was primary hypoparathyroidism with stress hypocalcemia. So in terms of managing electrolytes, we do watch out for low calcium, for low phosphorus, for low magnesium, for low potassium, and for high sodium. We can also see patients with low sodium, and there's specific management for each one of these. But if the ICU calls me in the middle of the night and says, we just got 5 a.m. electrolytes and there's some abnormalities, could this be due to mito? The answer is yes. And let's check why. Let's look at the endocrine organs, or especially the kidney. So we do recommend that our patients have an emergency care plan. It's always hard when your child or loved one is at home having a medical emergency, because then you know you either need to drive to the hospital or call 911. You're in the emergency room. There may be doctors right there on the front line that don't know mitochondrial disease. It can be very helpful for you to carry an emergency care letter so that it tells the emergency room what to do, and then it can also help the ICU. And there have been several things online, and there's a link there, the bit.ly/mitocare. The Mitochondrial Medicine Society has put together some emergency plans as templates, as have the United Mitochondrial Disease Foundation, but we will give our patients an emergency letter. Here at CHOP, Dr. Ganetzky and I have been very busy for at least the past year developing a care pathway, so that if a mitochondrial disease patient comes to the emergency room or is in the ICU, what should they be looking for so we don't miss anything? So if you have an emergency letter, please carry it with you or have it accessible electronically. In general, that care plan should include any contraindicated medications. If you've had a bad result getting propofol or any other medicines that we know we need to avoid. For example, the patient has Pol-G, Depakote is absolutely contraindicated. Then some anticipatory guidelines. What are we going to do for fluids? What about nutrition? What about antipyretics to control fever? And then patient specific. What is that patient specific diagnosis? What are some common acute complications? Do they need to watch out for cardiac disease, liver disease, renal disease? What's already the known organ involvement? What is that patient like at baseline? What's their typical neuro exam like? So the ER knows that the child is not themselves. What are their baseline nutrition needs? What's their cardiorespiratory status? Is this somebody who has a trach, but not necessarily needing a ventilator at home? So they need to know what the baseline is. They need to know what medications that child or patient has, what their allergies are. And then just very briefly, we do get into discussions in the ICU about ventilation and respiratory management. And I believe Dr. Ganetzky and I are having this conversation tomorrow. When do we place a tracheostomy versus when is non-invasive ventilation okay? So using more of a face mask. And so if a patient has been hospitalized in the PICU and they keep getting reintubated, they just cannot make it off the ventilator, then we start having the conversation with the family about tracheostomy, because it's very hard to be immobilized with a tube intubation on a ventilator. Once the trach is in place, there's a lot more freedom and less risk to the airway. We really like to involve our pulmonologists and ENT people who have specialty areas in things like muscular dystrophy, spinal muscular atrophy, because they're very aware of other impacts. So not just the brainstem issue in our patients with Lee, but neuromuscular weakness around the chest wall. And again, they can really help us out with deciding, is this a patient that might be okay with non-invasive ventilation? Again, if there's a brainstem lesion causing respiratory failure, that can be a very difficult problem to heal from. Almost all of our patients require long-term tracheostomy, with very few eventually getting decannulated. Again, it's possible to wean the ventilator over time, but then keep that tracheostomy there for safety, or maybe only need it when they're sleeping. And there is always the chance that it can be decannulated, meaning the tracheostomy can come out, and that can scar over in the future if they remain stable. There are a lot of training opportunities for families, for home management use, and inpatient rehabilitation for teaching and adjustment of vent settings, and to make sure the family is very comfortable if in fact that patient needs a tracheostomy for long-term management. The other important thing we talk about very early in the admission, even in the ICU, is that we want physical therapy and occupational therapy and even speech therapy involved as soon as that patient's stable. And if that patient is not back to their baseline, to consider whether inpatient rehabilitation is necessary. Now, there's a lot of caveats here. Sometimes our patients are just too deconditioned and weak and malnourished to benefit from aggressive physical therapy in an inpatient setting, and hopefully they're not malnourished if they've been getting good care in the hospital, but they can be very weak and deconditioned. And so sometimes they have to go home, build up their strength again, and then consider a more aggressive rehabilitation plan. If they're able to tolerate inpatient rehab, it's something that I absolutely recommend. It is much easier to go from the hospital to inpatient rehabilitation, because once you go home, people think you're going to be okay at home. It's very hard to be home and go back into inpatient rehab. Sometimes, and what we find in children especially, is that the benefit is enormous to go right to inpatient rehab. And at that point, you're tired. You just all want to be able to go home and sleep in your own beds, but you can get better faster if you go to inpatient rehab, where you're getting 8 hours of therapy a day versus going home and getting 1 hour a week. And so sometimes it's worth putting those extra few weeks in for maximum benefit and optimization of the best outcome as possible. We can also consider day programs for intense outpatient therapy, and again, just aggressive outpatient therapy if the patient can't tolerate inpatient. So we do involve physical medicine and rehab consult, PT, OT early in the admission. We make sure the equipment needs are in place, including any needed new splints for any new tone issues, such as new spasticity. If there's a new chair that's needed, all the things can be addressed during the inpatient admission. So our overall conclusions are that mitochondrial disease has acute multi-organ system decompensations. And I think I can speak for everybody. We've all seen it. Patients come in with one problem, they develop other problems while they're in the hospital. And so a general medicine or general pediatric team is usually best suited to take care of these patients when they're done with the ICU, because that way you have a team that's looking at neurology, NGI, or renal, or whatever the other issues are. We want to prevent further decompensation by avoiding catabolism, fever, and mitotoxins. So again, making sure that the patient's getting the right amount of fluids, the right glucose, the right nutrition, managing fever with all the things Dr. Ganetzky mentioned earlier, and avoidance of mitotoxins if appropriate. Supporting mitochondrial crises with arginine, N-acetylcysteine, and steroids for acute new brain lesions that have that associated brain swelling or edema when appropriate and not causing risk for other problems. And as Dr. Ganetzky went over, normalizing acidosis and electrolytes using sodium bicarb as the primary buffer, and not relying on lactated ringers, for example. Just getting back to the acute multi-organ failure and system problems, again, remembering what Dr. Mithal added about looking at the heart, considering dysautonomia treatments, so that we can make sure that all the organ systems are covered. And so with that, I'd like to thank you all very much for your attention. This was a really complex subject to deliver. We do also have this on MitoU for any clinicians that would like to hear this talk at local institutions. And some of us are also available to use this as a grand rounds opportunity at your local institution. So don't hesitate to reach out to the UMDF if you'd like to try to arrange that. And with that, we will take any questions that have popped up in the Q&A. Thank you so much for your attention.